Hello, everyone, and welcome to the D20 Lightning Talks, 5 Perspectives on Diabetes Stigma, brought to you by the diaTribe Foundation. I am David Lee Strasberg, and I'm Creative Director of the Lee Strasberg Theater and Film Institute, the world-renowned home for method acting, and I am a person who lives with diabetes. I'll be your MC tonight, and I'll tell you, when I was a kid, I didn't talk with anyone about diabetes. Right? Like my college roommates didn't know that I had diabetes for a solid year or two. College football coaches, nope. Rugby team, girlfriend, definitely not. Basically, I put it off as long as possible. And I didn't really think of it as a secret. And yet, at the same time, I actively hid it from the world. I really had no concept of stigma as a thing. Right? Just an overwhelming experience of not wanting people to know, right? To know that I was different, to think that I was sick, to know that I might be vulnerable in some way. And, make no mistake, that was stigma at work, right? My stigma, borrowed from the misinformed popular beliefs, right, all around me and wedged into that space between me and the world. Right? And that is where stigma sits, right? It resides in the altered relationships between those of us who live with or treat the disease and those who surround us, right? It is baked into these dysfunctional bonds that leave us isolated, lacking care, and vulnerable, right? As many of you know, the diaTribe Foundation's mission is to improve the lives of people with diabetes and prediabetes and obesity, and to advocate for action, right? And in pursuing that mission, it has become clear that you can't fully impact diabetes, right, the diabetes universe, without tackling stigma. It blocks us in every effort at systemic change, right? It causes people living with diabetes to distrust their own bodies, right? It means fewer appointments with your health team. It means less support for intervention that could improve your health, your productivity, and your happiness. Sluggish improvements and grudging care from a system that feels like it is designed to frustrate us. So stigma is this boulder that we need to move if we want to access real change in massive numbers. Right? And that is the mission, right? Make no mistake. The good news is we know change is possible, right? That we can liberate ourselves from our old beliefs, right? They don't have to be passed on. In fact, if you fast forward to my own son living with diabetes, who tests his blood sugar and has tested in the middle of his classes, right, where everyone can see, he was hospitalized one evening with an extreme low blood sugar. The next day, he didn't retreat into a shell, right? There was no retreat. He ran into school, and in the middle of the yard, he bragged out, "Hey, I had a seizure last night," right? So there was no hiding for him, right? No shame about what was happening in his body and his life. So today's conversation is about gaining a perspective on stigma, right? To identify it, to see where it lives and how it operates out in the world, so that, like other social movements before us, we can change hearts on the way to changing policies. So in addition to our speakers, you can help us understand the force of stigma. I imagine that most of you here have your own story about experiencing or reinforcing diabetes stigma. So any one of you who feels called to share, you can put your story into the chat on the right side of the screen. Right? I promise that the D-Network team will be collecting those stories to learn and to educate, right? Because sharing your story is a powerful first step. And your story will help us shape large-scale change. So your experience really matters. And we are going to bring diabetes stigma out into the open so that we can do something about it, right? Our talks will cover different perspectives on this disease and battles with social stigma. We'll hear from Anthony Anderson about living with diabetes as a person who is committed to speaking out. Rebecca Puhl will talk to us about what researchers have learned from a scientific perspective about stigma and its practical health impacts. Nat Kendall-Taylor will offer a perspective from outside the healthcare space on a strategic way to use communication to make real-world impacts on long-held beliefs. Right? Joan Garry is giving us some hope with a look back on how the tide was actively turned on the issue of marriage equality and on what real leadership looks like. And then Dr. Jim Gavin will share his rich experience, both as a clinician and a community leader, particularly in communities of color, and shed some light on the way forward. Following Dr. Gavin's talk, we'll bring all the speakers back onto the stage for a question and answer session with all of you, our audience. So I hope that you'll stay there with us for that Q&A. And if you have any questions that come to mind during the talks, once again, please put them into the chat there on the right-hand side. We'll be gathering your questions throughout, and we will be providing them to the speakers during the Q&A session. Please just remember, heads up, everything and anything that you put into the chat will be seen by everyone attending, right? No rookie mistakes, please. Before we start the program, also, it is my honor to thank the generous sponsors who are elevating this conversation, bringing it to this larger audience, and who also are supporting the work that diaTribe does every day to make us all smarter about diabetes and improve our lives. First, I'd like to thank our silver sponsors, Abbott and Sanofi, for their leadership support, and thanks to our bronze sponsors, Boehringer and Ingelheim, AstraZeneca, the Merck-Pfizer Alliance, and the Novo Nordisk, who's made the Anthony Anderson appearance possible, right? So first, let's begin with the star of ABC's Blackish, Anthony Anderson. He is an Emmy and Golden Globe nominated actor, and he is famous on pretty much every screen you've got, you know, on the big screen, the small screen, Android, iOS, game shows, guest appearances. This past August, by the way, Anthony was just awarded his star on the Hollywood Walk of Fame, which is pretty cool. And in addition to being the star of Blackish, he is also an executive producer on the show, where he plays Dre Johnson, who got his own diabetes diagnosis on the show in 2017. So in real life, Anthony was diagnosed with type 2 diabetes in 2002. And since then, he's helped define an award-winning education campaign called Get Real About Diabetes with Novo Nordisk, a worldwide diabetes company, for those who don't know. The program focuses on real talk for people living with type 2 diabetes to help motivate them and to get serious about managing the disease, and along the way to debunk some of the stigma and shame that often comes with it. The whole effort is informed by Anthony's own challenges managing his diabetes over almost the last 20 years. And this past April, also, the award-winning campaign was integrated into Blackish, the show, with the character Dre actually taking on the campaign at his agency, so to further raise awareness about the disease, further support education, and support all of us who live with the disease. Anthony was planning to be with us live today, but as Hollywood works, a last-minute production conflict made that impossible. But fortunately, I was able to sit down with him just a couple of hours ago, and I can share that conversation with you. So here, go on and take a look. Anthony, thank you so much for sitting down with us and sharing your story with me and with our audience. For those of us who don't know you and your history with diabetes, can you tell us a little bit about your story? Like, tell us about your diagnosis and kind of where all this started.
Well, I just made 50 years old this past August 15th. And this February, I believe, will make, I think, 20 years that I've been a diabetic, either 19 or 20 years.
I guess that's congratulations.
You say congratulations.
Congratulations. I don't know.
Yeah, it's either going to mark 19 or 20 years that I was diagnosed as a type 2 diabetic. And my story goes like this. I was working extremely hard, burning the candle at both ends, creating my first television show while promoting a huge movie. I was in 16 different states. I was in 14 different states in 16 days. Wow. And at one point, I was just exhausted, and I just found myself taking midday naps and whatnot, which was out of the ordinary for me. But I was like, I'm developing a new show. I've been in 14 different states in 16 days. all on commercial flights. I wasn't flying private. So just dealing with the hustle and bustle of airports and travel to and from airports. And I just thought that was taking its toll. And so I didn't pay much attention to the symptoms of being a diabetic at that point. And then maybe 10 days to 2 weeks after that had started, I'll never forget one night, in the middle of the night, I just had this unquenchable thirst, and it went from the middle of the night to the wee hours of the morning. And in the course of 2.5, 3 hours, I had drank 5 gallons of water.
Wow.
Yeah, and I know it was 5 gallons because I just put the 5-gallon jug on top of the water dispenser that evening.
Yeah.
And I kept waking up in the middle of the night, having to use the restroom. And every time I would use the restroom, I felt this need to drink. And as soon as I took the drink, I would have to go to the restroom. And I woke up the next morning, and I was like, I think I may have diabetes. And I went to the doctor, and on the way home from my visit, I got a call from the endocrinologist, told me that I needed to turn around and come back to the hospital, that my blood sugar was in the high 200s, and that I needed to come sit and consult with her and maybe take some insulin or whatnot. And that's how I was diagnosed with type 2 diabetes.
Yeah.
And I'm sorry, and just to follow up, you know what's crazy, once I was diagnosed and I was conscious of what the symptoms were, I realized that my dad had been a diabetic for probably close to 20 years at that time.
Wow.
Without being diagnosed.
Yeah,
You know,
undiagnosed. He was just toughing it out, right? Just going through his life.
Yeah. I had just gone back to my childhood, and I was like, all the things that once the doctor told me that I was a type 2 diabetic, it immediately came rushing to me. All the symptoms that I had were the symptoms that my dad had, but went undiagnosed. And you know, my dad never really went to the hospital, you know, and it's unfortunate that most men, myself included on occasion, rarely go to the hospital unless an appendage is falling off and we need to go. And so once I was diagnosed, I went to my dad, and at that time he had already been diagnosed, and then, you know, we were tackling this together. And then subsequently, 2 or 3 years later, my mom was diagnosed with type 2 diabetes.
Oh, I didn't know that.
So then it just became a family affair. And, you know, my dad's quality of life, because it had gone unchecked for so long, was pretty bad for him. And he started to make a turn for the better. And unfortunately, we lost him to complications of diabetes some years after he was diagnosed. But I didn't want that for my children. I didn't want that for my mom. I didn't want that for my family. So that's when, you know, I had a real reality check.
Yeah. You know, I'm sorry for that, for your loss. And, you know, and it's not so different, though, I guess, from so many people, right? Especially when it's undiagnosed. I'm curious, you know, given how you had to look back on his life and your life and say, like, oh, these things were always there. You know, I noticed on your social media, you identify yourself as, you know, just a kid from Compton. And I'm curious, like, did that kid from Compton know anything about diabetes? Like, when you grew up, was there any conversation around it? Had you heard of it? Like, what was the belief system or the knowledge at that point?
You know, there was no conversation about it within our household, because at that point, we hadn't been affected by it. You know, but we knew about the disease from friends, distant relatives or whatnot. Right. And, you know, just growing up, it was always, even though it's a serious disease, it was always spoken about in lighthearted way. Like, oh, you know, Aunt Vern, she got the sugars, right? You know, right. But there's nothing sweet about this disease, but we knew of it, hadn't had anyone affected with it directly in front of us within the family, but we just knew of friends who had it, friends of family members, distant relatives. You know, you hear stories like, oh, you know, so-and-so lost a foot, so-and-so lost a toe.
Right.
And it really hit home for me. Friend of mine named Gooch, after I was diagnosed, you know, I found out he was diagnosed as a type 2 diabetic, and ended up losing, and we call Gooch 9. And his nickname is 9 because he lost his big toe to complications of diabetes. So he only had 9. He only had 9 toes. After,
good save, by the way. Good save.
After that, yeah, thank you. He only had 9 toes.
Yeah.
After that, so thus the nickname 9.
It's interesting. Even that story though, like there's that sense of like inevitability in some way, like, oh, someone's got the sugars, and they, you know, that person, you know, you kind of make the joke, right? It becomes the nickname 9, but there is a resignation to that, right? Like there's a belief around like that is, of course, that stuff just happens, right? And as opposed to recognizing it as a treatable disease, a disease that can be, you know, can be challenged and managed and, you know, tackled. Right.
Yeah, you know, once I was diagnosed and knew what I needed to do, I made the choice that one, I wasn't going to die from this disease, but that I was going to live a healthy life with it. And here we are, knock on wood, you know, 20 years later, me still being as healthy as I can be, given the fact that I am a type 2 diabetic.
Yeah.
But, you know, still able to move around and do the things that I've always done, without the hindrance of the disabilities that can afflict someone with this disease.
Right. Right. So thinking about that, you know, this conversation is really about stigma, right? And when we think about stigma, this larger conversation of stigma of any kind really comes from, it's just stories, right? Like you know, you and I are both in the business of stories, telling stories, understanding stories, sharing stories. But stigma means that they're stories that just aren't the whole truth. That there are these stories that aren't necessarily true, they're not necessarily accurate, but they become beliefs, right? So I'm curious, like in terms of what you thinking about that kid and the people you knew growing up, and now where you are in this movement towards keeping yourself healthy, right? And making a commitment, right? Like, I'm not going to die from this disease. Because one of the things we do know, by the way, well-controlled diabetes, as some of my doctor friends are fond of saying, well-controlled diabetes is the leading cause of nothing, right?
Exactly.
So, you know, but I'm curious what you may learn new or unlearn, where there are thoughts or beliefs that you had to shift for yourself to sort of find this mindset, to find this, you know, this place in your life where you could be healthier.
You know, the myths that I grew up hearing is that, you know, I talked about it jokingly and in light, but, you know, losing a foot, losing a toe, losing your eyesight, all of those things that can happen and have happened to people with this disease who didn't manage it properly. You know, case in point with my father, who went undiagnosed for at least 20 years, and just how it affected his well-being. You know, leaking ulcers from the back of both of his calves. You know, swollen extremities and all that. So all of the things that, you know, were mythical to me at one point became my reality once my father health took a turn. And so, you know, until that was a reality for me, it was just like, well, I never knew anyone who lost a foot to diabetes, but you heard stories until I got older and was diagnosed, and my buddy Gooch lost his big toe.
Yeah.
Never knew of how it can really affect a family.
Yeah.
You only heard about those things until my father and how it affected us. And then it was like, so the myths, until they become reality, are just fantastical stories.
Mm-hmm.
And then all of a sudden when they hit home, you're like, oh, wait a minute. So all this was real. All this was true. All this can happen if not managed properly, if not taken care of, if not listening to what your endocrinologists and your doctors are telling you that you need to do.
Right. And that last piece, right? Like that all this stuff can happen. But one of the things I've seen from you, right, from me in my life, for myself and my son, but also in Blackish, right? Where, for those who haven't seen the episode, first of all, go back and watch Blackish. But your character, Dre, is diagnosed with diabetes. And I know that's, for those keeping score, it's, episode 9, season 4, Sugar Daddy. So you chose to focus on this in a way as part of the narrative of like, yes, all this can happen. It does happen. It's real. Right. But those outcomes don't have to be the same. Right. What happened to Gooch doesn't have to happen to everyone. What happened to your dad doesn't have to happen. I'm curious, like that episode, which is a brave thing, right? You don't have a lot of folks in Hollywood. You don't have a lot of folks in entertainment stepping out and really talking about diabetes, right? And I'm curious for you how that episode came about, right? Was it hard for you to make that happen? Like, what was the story there?
Well, how it came about is, Blackish is the stories pulled from our lives. And that's a reality of mine, being a type 2 diabetic. And, having the platform that I have, really wanting to teach, use this as a teachable moment, and spread information about this disease. And, very seldom, but it has happened in the past, and hopefully continues to happen, that, the leading actor on a television show or whatnot will tell these type of stories, these type of personal stories, to share with the masses and to help educate. And so that's where all of this had come from. And we had made jokes about, my character Dre being a diabetic, but never knowing if it were true or not. So we took this episode and made it reality. He went to the doctor and found out that he is a diabetic, and that all of the jokes were really true. All of the things that we joked about were telltale signs about diabetes. And here we are now with this character facing it in real time, in real life, as the actor who's portraying him is dealing with this in real time. And thus, my partnership with Novo to create a campaign, that we could bring to the world and talk about, diabetes and what you can do. One can do to try to avoid this if you're pre-diabetic. So we created our campaign, Get Real About Diabetes.
Yeah, tell me a little bit about that, because I know you actually reached out and found them, right? Like this is something that you felt strongly about. You decided you want to do it. For those who haven't gone there yet, getrealaboutdiabetes.com. Go check it out. But tell me about that effort. Like, what does that mean? Like getting real about diabetes. What do we take from that?
That's it. Getting real about it and dealing with it head on. Getting as much information about the disease and about you as an individual and how you can combat this and live a long, prosperous, fruitful life as a type 2 diabetic. And I believe that Novo and I kind of reached out to each other. I had already been in the diabetes space just telling my testimony and sharing my story with communities. And a mutual friend had reached out and asked me if they could introduce me to someone, to Ambry. And I said, sure. And we had this conversation about what it is that she and her company Novo could do with me within the community, and talk about diabetes. Again, talk about my testimony, what brought me to them, why I'm willing to share my story, and how it can, and how sharing that story can affect and help people who are facing this disease.
Yeah.
And it's informational, it's testimonial, it's all of that. And we've had this partnership for a few years now, and people stop me on the street. They see my transformation, and they're like, yo, I saw you, and because of your transformation, I've lost 120 pounds.
Wow.
I was in Vegas not too long ago, or last week, reopening Planet Hollywood. And as I was walking through the casino, heading back to the car to come back to LA, a young gentleman stopped me, a young African-American man stopped me in his mid-20s. No, late 20s, early 30s, possibly. And pulled out his phone and had a before and after picture of himself and said, hey, Ant, I just want to let you know, man, because of you, look at me now. And he had lost 100+ pounds, man.
Wow.
And so that just goes to show me that what we're doing with Novo and Get Real About Diabetes and our campaign and all of that is really having an effect on the people that we want it to have an effect on or with. So that's what it's all about. That's what it's all about, in getting information and sharing my testimony and helping people to make a change in their lives for the better.
Yeah. Well, let me just tell you that those of us who are in the space really watching what's going on in the diabetes space, notice the good work that you and Novo Nordisk are doing together, and I think that the real world impact is there, it is visible, and we appreciate it. I'm curious, just to close this conversation, if there's any advice you would give to our audience, to all of us, as we take on the work of like fighting diabetes and diabetes stigma, right? Fighting these beliefs, and if you have any advice for us going forward.
Being diagnosed with diabetes is not a death sentence. It's not, the disease can be debilitating if you allow it to get to that point. But Novo Nordisk, as well as other pharmaceutical companies out there, have made tremendous strides in the medication that's needed to aid in reducing those risk factors that contribute to death, to amputation, to heart attacks, to strokes, and to all of that. So I just want people to know out there that it's not a death sentence being diagnosed as a type 2 diabetes. Listen to your endocrinologist, listen to your medical team about what you need to do in order to have a long life, a long, healthy life, while being a type 2 diabetic. Take heed to what they're saying. Stay on your routine with your medications. Exercise. You don't need to be a member of a gym to exercise. You can get out and run around your block, walk around your block. You can exercise in a small room in your home. Just be active. Those are things that I would give to people. And our campaign and GetRealAboutDiabetes.com is all about empowering people with information as to how to become and stay healthy. That's what I would say. It's a lifestyle change, but it's one that will work out for you in the long run. And it's not that drastic. All things are good in moderation. But, you know, you also have to be cognizant of the fact that it's like, okay, well, if I eat this slice of cake, what is it going to cost me tomorrow? Mm-hmm. Well, it's going to cost you an extra 45 minutes in the gym. It's going to cost you an extra 45 minutes on that walk or that hike or whatever it is that you're doing. Mm-hmm. You know, that's what I would tell people. Yeah. You know, that's what I've been telling people. And I try to lead by example and show them, hey, everything that I'm asking you to do, everything that I'm saying you should do, I'm doing. And I'm a byproduct of all of that. And knock on wood, I'm still almost as healthy as I was. Actually, I'm actually healthier than what I was 20 years ago when I was first diagnosed. Because 20 years ago, I was 70 to 75 pounds heavier than what I am right now. Mm-hmm. So yeah, I'm actually healthier and more fit today after being diagnosed as a type 2 diabetic than what I was pre-diabetes.
Yeah, right. Well, you know, all the things that you described, they're things that everybody should do, right? They're things that keep everyone diabetic, non-diabetic, you know, whether you're living with this disease or not. But the stakes are higher when you got diabetes in your life, right? So they're good, healthy habits for everybody. But you know, the ramifications are more if you've got diabetes, right?
Yeah. Well, I'm sorry. I just want to say, I also would encourage everyone who has an interest in diabetes, because they're diabetic or they're pre-diabetic or a family member is, educate yourself as much as you possibly can about the disease, what contributed to the disease, and what you can do to make your life and lifestyle easier and better after being diagnosed with the disease. I would say that as well.
Yeah, yeah. Well, and you can check that out also at getrealaboutdiabetes.com with what you do with Novo Nordisk. Also, for those, you know, who are part of this event, you know, the work that at the diaTribe Foundation is all about making people smarter about diabetes. So I encourage you all to look at diaTribe.org. Anthony, thank you so much. I appreciate your time sharing this conversation, elevating this conversation. It's really important, and we all appreciate you and what you're doing.
No problem, Dave. Thank you for taking the time to speak to me, man. I appreciate you for that.
You're welcome. Break a leg today.
Thank you, buddy.
All right.
All right.
And now we're going to go back to our live event, and we'll transition over there. But we're going to also now move to Rebecca Puhl. So have you ever heard of a doctor, like you heard them talk, right? And you say to yourself, like, wait, are they speaking English? Right? Like, I'm not sure sometimes that we speak the same language, right? So Rebecca Puhl is a professor of human development and family sciences at the University of Connecticut and deputy director of the Rudd Center for Food Policy and Obesity, where she leads policy and research efforts aimed at reducing weight-based stigma and discrimination. And she is someone who is trying to bridge this gap of understanding between that belief system that we call stigma and the scientific manifestation of those beliefs as expressed in medical health outcomes, right? Actual health outcomes of real people, right? She's a national research expert on weight stigma and has testified in legislative hearings on weight discrimination. She routinely provides expertise on strategies to reduce weight bias to national and international health organizations, right? And she is here with us today. Welcome, Rebecca. Thanks for coming. Thanks for joining us.
Thanks very much. And thanks for the invitation to speak to you today and to be a part of the important discussions in the D20 forum. So as a researcher, I've spent almost 20 years studying stigma and discrimination toward people who have obesity. And today I'd like to talk about how important it is to have research on disease stigma in order to effectively raise awareness, mobilize change, and inform policy. And specifically, I'd like to share with you the ways in which our research has really helped to address obesity stigma, which has many parallels to diabetes stigma. So first, it's important to understand why disease stigma exists if we want to effectively change societal attitudes and reduce stigma. Disease stigma is a social construction of illness. It involves making moral judgments about the reason why a person has their disease and the pre-existing attitudes that we have towards groups of people who are most affected by the disease. And disease stigma occurs when people are blamed for their disease, when they're assumed to be personally at fault or lazy or immoral or lacking in willpower. And as a result of these stereotypes and assumptions, people are harmed not only by the disease itself, but by public and social responses to their disease. And the harmful impacts of disease stigma are numerous. We know that stigma worsens disease outcomes and health disparities that already exist for individuals who are most likely to be affected by disease. It induces stress-related illness. It lowers quality of care. It impairs preventive health behaviors and patient-provider communication. It reduces healthcare utilization. It interferes with effective prevention and treatment. And beyond these direct consequences for physical health, it creates inequities in employment, and it worsens social relationships, and it really simply worsens the quality of a person's life. And this information isn't new. We've known this for many decades, that stigma impairs health. And the list that you see here on this slide reflects examples of diseases or conditions that have been stigmatized, ranging from cholera to HIV/AIDS. And what these all have in common is that there's been broad recognition that stigma undermines their prevention and treatment. And public health policies have been created to address stigma as a legitimate barrier. And this has led to increased funding and research and programs to address stigma. But other stigma-related diseases haven't received this kind of attention. And when I started as a researcher studying obesity stigma, it wasn't recognized as a disease stigma. It wasn't on the radar. And although there is a long-standing consensus that stigma undermines public health, this principle really wasn't being applied to obesity. So I'd like to share with you what we've learned from our research on obesity stigma and the ways in which research has really been critical in efforts to bring attention to obesity stigma and actions to address it. And this is relevant to diabetes stigma for several reasons. First of all, like obesity stigma has been for a very long time, diabetes stigma hasn't received the attention, the research, the funding, or policy action that it needs. Second, obesity stigma is highly relevant to diabetes, given that many people with type 2 diabetes also have obesity. And third, obesity and diabetes share many of the same stigmatizing characteristics. So that is, foundational assumptions and stereotypes about obesity and diabetes strongly overlap in many cases. Both of these are diseases in which people who have them are assumed to be personally at fault and to blame for their disease. They're assumed to have developed their disease as a result of lack of willpower or discipline, or being unmotivated to improve their health, and assumed to be non-compliant with treatment or intervention. And these are the foundational beliefs that need to be changed to shift the current culture of blame towards obesity and diabetes. So I'd like to share with you the ways in which research has been critical in efforts to address obesity stigma, particularly over the past decade. And there are 5 key roles that research has played to help shift societal attitudes and mobilize change. The first is that research has provided a necessary foundation of knowledge and scientific credibility to the issue of obesity stigma. Second, research on obesity has played a key role in helping to increase public awareness of this issue. Third, scientific evidence has helped to mobilize the medical community to take this issue seriously. Fourth, research studies have provided evidence that have been instrumental in influencing policy initiatives. And 5, science has been absolutely necessary to develop and test effective strategies to reduce weight stigma. So I'd like to spend a few minutes highlighting some examples of each of these. So first and fundamentally, to convince the public, the medical community, and policymakers that obesity stigma needs to be addressed, we first needed to provide the facts. We needed to have a foundation of clear evidence to convince people that obesity is a prevalent problem facing Americans. And through multiple national studies in the US, research has established that weight discrimination affects up to 40% of the population, with rates highest among people who have the highest body weight, and especially among women. Research studies also show that weight discrimination is very common compared to other forms of discrimination in our society, like age and race, and that it negatively affects people in many different societal settings. This kind of evidence was really key to help demonstrate weight stigma as a legitimate problem and to give it credibility. Now, part of this foundation of knowledge also involved research evidence to show the many harms of weight stigma. And we've learned from research that in addition to the emotional distress that people experience because of weight stigma, it also worsens their eating behaviors, it lowers their levels of physical activity, and it even worsens their body's physiological stress responses. Moreover, a striking finding in research is that experiencing weight stigma predicts increases in weight gain and obesity. And this evidence has been particularly important in challenging societal weight stigma because there remains widespread beliefs in our society that stigmatizing people or shaming them about their weight will motivate them to lose weight. That stigma will somehow provide an incentive for weight loss. But what we see from science is the opposite is true. Stigma is actually contributing to the condition that people are being stigmatized for having. And collectively, this scientific evidence has been very important in convincing the medical community that weight stigma is harmful to health, and that this is a public health issue and that weight stigma cannot be ignored. Now, a second way that research has been important in efforts to address obesity stigma is that it has provided key information that has been broadly disseminated to increase public awareness. And part of the responsibility of researchers is to communicate their research findings to groups who can use it for meaningful action. The mass media is one of those groups. And a lot of our research on weight stigma has received national press attention, which has really helped put this issue on the radar in the general population. So we've worked very hard to establish positive relationships with reporters and news outlets who really look to us as credible scientific experts on this issue. And all of the media pieces that I've highlighted on this slide report on how weight stigma harms people's lives using our research evidence. And so broadly, as part of efforts to address disease stigma and diabetes stigma, there needs to be ongoing communication between scientists and the press to disseminate relevant and compelling evidence to the public. A third way that research has been critical is to mobilize the medical community to address weight stigma. And in particular, research evidence demonstrating the harmful health consequences of weight stigma has been very influential in both increasing awareness in the medical field and in motivating actions to address this problem. And a recent example to highlight here on this slide is a joint international consensus statement that was published in the journal Nature Medicine in March of 2020. More than 100 medical and scientific organizations worldwide endorsed a consensus statement based on the scientific evidence of obesity stigma, and they pledged their support to end obesity stigma. This initiative was completely driven by the scientific literature. And really, for the first time, we have a global group of experts and organizations that are speaking with one voice to condemn obesity stigma and pledge to help address this problem. Now, another example of the importance of research evidence is the role it has played in providing relevant evidence for policy initiatives to address obesity stigma. Science on the prevalence and the harmful health consequences of weight stigma have been very important for several different policy initiatives. One example is efforts by state legislators to introduce state legislation to prohibit weight discrimination. Massachusetts has actually introduced this legislation a number of times and is getting closer to a victory. A second example is the American Medical Association, who passed resolutions in recent years to address obesity stigma through education of healthcare providers and non-stigmatizing language and communication. And a third example is the American Academy of Pediatrics, who published the first policy statement on weight stigma in children. And that policy statement summarized the research evidence on the harmful consequences of weight stigma affecting children and really recommends that pediatricians address weight stigma in their clinical practice with youth and families. None of these policy initiatives would have progressed or been established without research evidence. And finally, we simply can't effectively reduce disease stigma if we don't understand the origins of stigma and how it works. And research has been critical in identifying strategies to tackle obesity stigma in our society. We've observed from this research evidence how important it is to target people's beliefs and understanding about the causes of obesity and to use multiple stigma reduction intervention methods. We're also seeing, though, that this is a difficult form of stigma to eradicate, and it appears to be more resistant to change than other forms of stigma in our society. So if we want to successfully shift societal attitudes, we need evidence-based strategies that will work. Changing societal attitudes is complex. It's not easy or straightforward, and science is key in order to make progress. So the examples I've just highlighted all emphasize why research is important in reducing disease stigma. Now, research on diabetes stigma does exist, but it's somewhat sparse and scattered compared to science on other disease stigmas, and we need more research to help tackle this problem, particularly in the US. So I'd like to share with you some of my team's very recent research published just last month on diabetes stigma among Americans who have type 2 diabetes. And essentially, we found that 40 to 60% of adults with type 2 diabetes reported experiencing different forms of diabetes stigma. And people who reported these experiences were more likely to have unhealthy eating behaviors like binge eating. And in addition to experiencing diabetes stigma, we also assessed whether people with diabetes were internalizing this stigma, blaming themselves. And we found that when people internalized diabetes stigma, they had higher diabetes-related distress, worse diabetes self-management, lower quality interactions with doctors, and they were more likely to engage in unhealthy eating behaviors compared to those who weren't internalizing diabetes stigma. Now, in this study, we also examined weight stigma in these adults with type 2 diabetes. Over half of them reported experiencing weight stigma, and more than 40% said that they felt judged about their weight by doctors. Again, adults who experienced weight stigma had higher diabetes-related distress. They had more unhealthy eating behaviors compared to those who were not experiencing weight stigma. And we saw the same pattern again when we looked at those who were internalizing weight stigma and blaming themselves, who were more likely to have diabetes distress, worse interactions with doctors, and worse health behaviors. So these findings tell us that high percentages of adults with type 2 diabetes are experiencing both diabetes stigma and weight stigma, and many are blaming themselves. And this has concerning implications for both their health behaviors and their health care. But we have a lot more to learn here. More research on diabetes stigma is needed so that we can really build a solid foundation of science that can help elevate awareness of this problem. We need to learn more about how prevalent diabetes stigma is and who is most at risk, and the ways in which diabetes stigma interacts with other stigmatized identities and how it impacts health and health care and what strategies will be most effective to intervene. If we want to successfully address diabetes stigma, answers to these questions are needed. And optimistically, we're seeing increasing calls for action in the diabetes field to elevate diabetes stigma as a priority. The International Diabetes Federation has identified stigma as a problem requiring attention and prioritize reducing stigma for people with diabetes. More recently, Diabetes UK has identified social stigma as a key area needing increased financial investment and research. And this year, the American Diabetes Association stated that addressing diabetes-related discrimination and unfair treatment is a key state and federal legislative priority. These are really important declarations, and they reflect the recognition that diabetes stigma is present and potentially harmful. So looking forward, the more that we can promote general awareness of diabetes stigma with the support of different organizations, the more we can encourage research and scientific attention to this issue. Effective advocacy and societal change needs policy-relevant science. So as we think about initiatives and strategies to address diabetes stigma, we need to expand existing research efforts to actively engage researchers, to strengthen the foundation of knowledge and evidence on diabetes stigma, to disseminate this evidence broadly, to educate and mobilize the medical community and inform policy initiatives, and to ultimately identify the most effective ways of ending diabetes stigma so that we can really shift the current culture of blame and shame to a culture of support and respect for individuals with diabetes. So I'll end there, and I'd like to thank you for your time and attention.
Thank you, Rebecca. I appreciate that. I mean, there's so many insightful things, but in particular, I love the shedding some light on this fact of like this vicious cycle, right? That there's a self-fulfilling prophecy around stigma, right? As well as the fact that there's evidence here, that, like you're providing scientific evidence, data, actual data points that tell us that diabetes stigma isn't just in our head, right? It's not just like something, oh, I know I shouldn't feel this way, and it's like something that I've made up. Right, it's like someone who has pain, right? And no one believes in the pain, right? Like it's not real. So I think both of those things really stood out to me, and I appreciate you sharing that with us today.
Thank you very much.
As we move through this conversation, and for our next speaker, Nat Kendall-Taylor, I'm just going to open a question to you all. How many times have you met an academic anthropologist, right, who says that, just with no sense of irony, I just want to help make real change happen? right? Well, today we are 1 for 1 on that one. Nat Kendall-Taylor is an anthropologist, and he is also the chief executive officer of the Frameworks Institute. So Nat oversees the organization's pioneering research-based approach to strategic communications. There he is. And they use methods from social and behavioral science to measure how people understand complex issues and then test the ways to reframe them, right, to drive social change, right? He's also the senior fellow at the Center on the Developing Child at Harvard University, a visiting professor at the Child Studies Center at Yale School of Medicine. And he's a guy who told me straight out, I know some things and I can do some things. And he's pretty confident that those things can help us change how people interact with diabetes and the stigma that surrounds it. So now let me introduce you all to Nat Kendall-Taylor. Nat, take it away.
Thank you very much. And I'm going to share my screen here. Just give me 1 second. And I should be good. Well, thank you very much. And it's important to know that after I said that to David, I said, but there's a whole lot more that I don't know, just so you have some sense of my hopefully humble presentation of what is to come. I just want to say that I'm super glad that that video worked, because if it didn't, I was going to be a dismal and very disappointing consolation prize to Anthony Anderson. So this is going great. I'm so glad that that worked, and I'm so glad that I get to be here with you all to do my absolute favorite thing in the world, which is to talk about framing. And I realize that's utterly sad and pathetic, but it does mean that for the next 15 minutes, there's going to be one person on this call who's having a good time. That will be me. I will have fun. I wanted just to thank the diaTribe Foundation for inviting me, and no offense, but the most important thank you is to all of you who are on the line right now, spending your time with us. And I realize that time is very valuable, and in exchange for that time, I'm gonna do my absolute best to use the next 15 minutes to be as utterly helpful as possible, talking about something that is pretty far outside the medical field and certainly the diabetes field. So that's really important that you know that I'm neither of those two things. So I'm not an expert in diabetes, and I am a doctor, but I'm not the kind of doctor that stands up when someone asks if they're a doctor on the plane. I'm a psychological anthropologist by training. And what I do and have done for the last 20 years is study how culture influences the way that people think, how people use culture to process information, to make meaning of messages, and to formulate and reach decisions. And so I'm super glad to be here with you today. And one of my goals is that at least one of you is at least half as excited about culture and framing after I'm finished here. I think I can do it. I'm a fan of nice low bars. So let's get to it. At the beginning, so I'm going to be talking about framing for the next 15 minutes. I think it's important that we establish a kind of common definition of what that term means. It's one of these words like narrative change that has become so ubiquitous that I fear it has lost any and all meaning it ever once had. So what we mean on this call, what I mean for the next 14 minutes is by framing is the choices that we all make and how we present information. And sometimes those are really small choices and seem rather insignificant. The pronouns that we use, whether we talk about us and them, or whether we talk about we and ours, the verbs that we choose and how those verbs either imply or deny agency to various groups of people, as well as the really kind of more obvious and in-your-face choices that we make as communicators, the values that we endorse to argue for why addressing an issue is so important, the metaphors we choose to explain how something works. Framing is about how all of those choices, big and small, that we make as communicators, and I'm going to argue that each and every one of us on this webinar right now is a communicator. Framing is about how those choices influence how people think, how they feel, and what they are or are not willing to do as a result of hearing what we have to say. I'm going to give you an example of what this looks like. As I said, I'm not an expert in the field of diabetes, nor am I an expert in framing diabetes, but I have worked on a number of issues that have kind of as their crux or as their turning challenge this issue of stereotype and stigma. So I've picked an example that comes from some work that my organization, the Frameworks Institute, has done on framing child mental health. And so we work with an organization who has as their mission to take the science of early childhood development and translate it for people who are in policy and practice making positions. And these scientists struggle mightily to communicate the particular concept within the larger field of early childhood and child mental health. So most Americans don't believe that very young children can even have states of mental health. And they're also not wildly supportive of using more public funds to support the mental health of young children. So that was really our challenge in this piece of work, to figure out ways of framing, of communicating the issue of child mental health that increased people's sense of the importance of the issue, what we call in communications salience, so kind of its top of mindness, where it sits in the issue agenda amongst other social issues. And then really pragmatically to increase support for the kinds of policies and programs that intervention science has shown are effective in improving healthy child development and supporting child mental health. So you're going to see one particular piece of that larger research project. It's a survey. It's an experimental survey that was conducted with just over 6,000 people. And how this experiment works is that each of those 6,000 people is randomly assigned to read a message on the screen. And the message is basically a description of a child mental health program, except it's framed at the top with a value. So a third of the people who are on this experiment get randomly assigned to a value of future progress and social prosperity. So they would read an opening to this description that sounds something like, we need to do a better job of addressing child mental health because, and we wouldn't say it in such a hackneyed and cliched way, because children are our future, right? They're stable, they're solid. Mental health is really important to our ability to progress as a country, to move forward and be successful. Another third randomly assigned of the larger sample gets assigned to hear the value of vulnerability. So they read the same 80 words, right? It's the same description of the program, except the lead-in, the first 10 to 15 words at the top is different. So instead of social progress and prosperity, these folks would read something like, it's important that we do a better job to support children's mental health because children are our most vulnerable citizens. They deserve our empathy and our compassion, and we must feel for them and do better by them. And then, yes, I can do math. That leaves 1/3 of the sample, which gets assigned to the control condition. So the control condition, in this case, is people who see no message, right? They read no message. They are this thin zero line that you see across the middle of the screen. And then everyone, regardless of what frame, what message they were exposed to, answers the same set of questions, which are designed to measure how supportive they are of this set of evidence-based policies. So what you're going to see on the next screen are what I think are two absolutely gorgeous green bars are going to appear. And those green bars are going to show you the extent to which hearing those two different frames, right, the different ways that the issue are framed, affects people's support for those policies. And I don't know the kind of statistical acumen of this audience, so I'll give you a quick stats lesson in regression analysis. Up is good, and down is not good. So you see on the left-hand side of the screen that value of collective progress and prosperity is having a strong and statistically significant positive effect on people's support for those policies. That's good news. When we get those kind of results, there's a little framing dance that we do. Don't worry, David, I will not do it now for anyone here on the webinar, but your eyes probably also wandered towards the right-hand side of the screen where you see news that is decidedly less positive. So that value of vulnerability is not only 0, which remember is no message, but it is actually depressing people's support for these policies that the field is advocating for. So let me translate that for you. If you're an expert or an advocate working on issues of child mental health in the United States and you use the value of vulnerability to frame your messages, you not only waste your breath, you not only waste your valuable communications resources, but you use those very resources in a way that directly disadvantages your goals as experts, as advocates, as researchers. And just to be clear, when it comes to communications, that is not what you want to be doing. That is not good news. The really interesting thing is that after this experiment, we conducted a systematic analysis of all of the field's external facing communications over a 3-year period. So this is all the websites, the press releases, blogs, the mission statements, the pamphlets. And guess which value we found to be used in over 90% of those communications. And because of this format, that has to be a rhetorical question, unfortunately. That is the value of vulnerability, right? So what we found, in essence, that for a long time, with a shocking amount of resource, the field had essentially been using a value that, again, not only wasted those resources, but used those resources in a way that directly disadvantaged their goals as advocates. So I've come to think about framing through a metaphor, and it's the idea that these frames that we use and choose, these choices that we make as communicators, are not just kind of purple prose that sound good and adorn our information, but rather they are these vital keys that we have that can unlock thinking, that can create space for people to engage with our issues in new ways, that can advance and provide a channel for people to come to support the kind of solutions that we know are vital and important to addressing a problem. That's the kind of optimistic entailment of the key metaphor. The negative entailment, the negative meaning, is that those frames can also do the opposite, right? The choices that we make inadvertently, in the case of vulnerability, lock down thinking, freeze up understanding, have people reject our messages, or worse, have them take the exact opposite message that we intend from our communications away from that engagement. And we know that framing has always mattered. So I've been doing framing for a very long time. It has mattered for each and every year, for each and every month, for each and every minute that I have done it. But it is really important and has really mattered in some obvious ways over the last 7 months. And I have collected over the last 7 months examples of framing that there's really solid research shows has some unintended, or some cases intended, but negative effects. And so I wanted to just take you through a number of these. And I think that both the child mental health and the vulnerability example is well chosen, I hope, for the work that you all do. And I hope that these examples also illustrate and provide some commentary on some of the main framing challenges and framing effects that exist around the issue of diabetes. So the first and the most obvious is the one that emerged early on in the pandemic, where the pandemic was labeled the Chinese virus. And this is a very well-studied and accepted finding, is that what this framing does, and I would argue deliberately, is it creates a palpable fear of others. It creates a kind of insular nationalism, and most interestingly and important, it elicits a sense of racism or a racist response that we have found not only attaches to the group at which this frame is directed, but in some really ugly ways kind of wiggles and wanders and attaches to all different kinds of groups of people around which there are well-held societal and cultural stereotypes. The second one of my personal favorites, is the way in which public health measures have been labeled as draconian in their approach. And what this does really strongly and immediately is create the sense that these measures are an obvious overreaction, and elicits a sense in which we are resistant to information and hesitant to act on what is vital public health advice. Another one, which relates to the child mental health one, is all the ways in which certain groups of people are being labeled repeatedly and explicitly as vulnerable. I think this is most pernicious when it comes to how older people are being labeled. And we know in the last 7 months, but there's a long and rich history of scholarship that looks at vulnerability framing and finds that what it does is it instantly others, right? It instantly creates an us and them perspective. It creates really strong zero-sum thinking in which any more for they and them over there means less for me and mine over here. And it perpetuates stigma. Stigma not only in terms of how we think about certain groups of people, but as Rebecca talked about, how individuals within that group think about themselves. Imagine being in a group and being told continually, repeatedly over time, that your group, as a group, is being essentialized as vulnerable, and what kind of effects that would have on your identity and all kind of behaviors and health impacts that ensue. Another one that we've been seeing a lot is people of color being infected or dying at higher rates, and there's really good research that shows that what this does is that it unfortunately does not send people's attention going to the structures and the systems that explain this phenomenon, but actually sends people back to blaming individuals and their choices and their health behaviors and their quote-unquote values in creating these disparities. And last but not least, related to, but kind of the second issue that we've been up against over the last not quite 7 months is this call to confront racism, and how we have seen that there's some framing effects that go on here, right? And what this does is that, again, it doesn't send people focusing on the systemic and structural features of racism, and instead it leads people to blame the kind of bad apples that have hateful or backward ways of thinking, and to try to root them out of systems rather than to change the systems in which they are operating and embedded. And so I want to end with a quote. This is one of my favorite new quotes about framing. It's from a guy named Charles Eisenstein, who is I think he calls himself a philosopher. He is a purveyor of awesome quotes. And this is really a powerful way to think about framing and what it can do for a social issue like the one that you work on. And so Charles Eisenstein said, "The world as we know it is built on a story. And to be a change agent is first to disrupt the existing story of the world, and second, to tell a new story of the world so that people have a place to go." And with that, I'd like to say thank you. I'd like to encourage you all to go out and frame on.
Thank you, Nat. Wow. I mean, so I am officially now super excited by framing. So you have succeeded. As a side note, I might still hold you to that framing dance. We might need to see that in the Q&A. So just heads up, get ready, work on your camera angle. But I think this whole notion of framing, obviously from where I come from in terms of method acting, everything is a communication, right? But it's one thing to know everything is a communication, but to see the power of that communication, right, is really impactful, right? And this last notion of disrupting the story is incredibly powerful. So I think one of the things I would add to Eisenstein's quote is for us to recognize, as we're going to disrupt the story, know that we're part of it, that we're actually part of telling this story, right? The way that we communicate, the way we frame, the way we live, frankly, the way I have lived my life as a person with diabetes contributes in at least some way to the framing and therefore to the story, right? So there's responsibility on us and opportunity, both together. Those two things always come in the bundle together. But thank you for adding that to our conversation today. Next up, we have Joan Garry. So I gotta tell you, sometimes you meet somebody and right off the bat, like instantly you go like, oh, like this person's the real deal, right? Like that exactly was my thought. That was my reaction when I first met Joan. Like I just thought like, oh, she's the real deal, right? So she was part of the team that launched MTV, right? Come on, forget about it, right? She was an exec at Showtime. And then as she says, she was either in a midlife crisis or avoiding one when she became the executive director of GLAAD, one of the largest gay rights organizations in the US, and navigated it through perhaps its most important decade, or at least as it was helping to redefine what it meant to be gay in America. She's an elite executive coach for CEOs at some of the nation's most impactful organizations. And her blog, podcast, and her book, check it out, joangarry.com, 2 R's, has become almost like a Dear Abby of the not-for-profit sector. She is laser focused these days on developing and supporting both leaders and leadership, right, in some of the most important not-for-profit sectors that exist. And I'm particularly impressed, and I think you will be too, with her ability to integrate joy into mission-driven, passionate endeavors, right? She'll help us hopefully connect the dots today, right? Between our thinking, right, this cognitive side of strategy, and this passion, our heart, right, as well as the realities of how things have actually gotten done on the social challenges that have preceded us, right? So please welcome Joan Garry. Joan, take it away.
Hey, David, thank you so much.
You're welcome.
I wanted to just begin by saying that I was really grateful for the opportunity to join you this afternoon. I wanted to thank Jim Carroll for Jim Carroll's an old friend, and he came a knocking and said, wouldn't you like to do this? And he kind of had me at hello. Your work matters to me quite personally, and I'm going to share a little bit about that a little bit later on. Nat spent some time, and David as well, talking about narrative and framing. And that last quote, inherent in Nat's last quote, is yes, you can change the story. And that's what actually my story is about today. And the thing I want you to really remember is that you have the power to change the story, the narrative about diabetes. You can change hearts and minds. And in fact, actually, it's the only path forward. It's the key to ending discrimination, to making real and lasting change. It's the key to advocacy. And I know what I'm talking about here because I am a member of the LGBT community, and I was a national LGBT leader. And I have been an integral part of this journey to change hearts and minds about LGBT people. And so in the spirit of this notion of changing the narrative and storytelling, my talk today is in fact a story. I'm going to take you on a journey. And assuming I can actually get my slides going, we're going to do just that. All right. So my story begins in 1968. This was the first documentary about gays and lesbians. For gay people who saw this, they will never forget it. It was deeply defamatory and chilling. I might put a link to the YouTube video in the chat or at some place so that you can really get a grip of it. But I want to quote from the open of this CBS report. Remember, 1968. Mike Wallace was the host, and he has subsequently apologized endlessly for this documentary. And he says this: homosexuality is an enigma. Even in this era of bold social mores, it remains a subject people find disturbing, embarrassing, a real reluctance to even broach the subject. And yet there is a growing concern about homosexuals in society and their increasing visibility. In preparing for this broadcast, CBS News commissioned a study with the Opinion Research Corporation into attitudes towards homosexuality, and we discovered that Americans find homosexuality to be more harmful than adultery, abortion, and prostitution. That's where we were in 1968. The next year, 1969, Stonewall Inn, the West Village, a peaceful evening for gay men enjoying themselves in a club, a police raid. It was the beginning of the marker of the modern gay rights movement. But what I want you to look at is the headline. Headlines tell stories. Homo nest rated queen bees are stinging mad. Trust me when I say this was one of the tame ones. We then move on to 1973. 1973. The American Psychiatric Association declares that homosexuality is no longer a mental illness. But I'm here to tell you, it was already too late. I want to read you another quote from the CBS documentary. Listen to this one carefully. The average homosexual, if there be such, is promiscuous. He is not interested in, nor capable of a lasting relationship like that of a heterosexual marriage. His sex life, his love life, air quotes, consists of a chance encounter, a series of chance encounters at the clubs and bars he inhabits. Inhabits. You realize how actually dehumanizing that word is? Quick one-night stands are characteristic of the homosexual relationship. You see, the APA decision was helpful, and of course it was a big day for the gays, but the damage was already done. Disordered, sick, mentally ill, somewhat akin to type 2 diabetes. Somehow or another, we could make this different now, right? We could repent. We could see a shrink. You could lose weight. You could stop buying Malamars in bulk. In these days, gays were invisible. And when we were visible, we were only men. And the stories that were told about us amplified these damaging stereotypes. In nearly every state, homosexuality was a criminal act. And if you wanted to read about homosexuality in the news, the place you'd most find it was in stories about men arrested for having sex in public parks. And do you know how often, when those men's names were published in those papers, those men took their own lives? Way too often. You see, gays were just sick. And then they really were. 1980s. And for so many, it was just oh so fitting. Gay men were just getting what they deserved. Of course, this is what happened to sinners and perverts. Meanwhile, Ronald Reagan said and did nothing. Legislators said and did nothing. Millions of dollars were raised independently to start organizations like GMHC and AMFAR. Elizabeth Taylor and other celebrities saw people dropping like flies around them and put their time and treasure to bring organizations like AMFAR to life. And it actually wasn't until Rock Hudson came out and died, which were almost at the same moment, did the lens on the topic shift at least a bit. And in some ways, this was the tipping point. The gay community rose up, marched in the streets for their dead brothers, for the rights they deserved. It's a pretty grim story. But from 1985 to 2003, something happened. A cultural sea change. We went from sick and diseased, disordered, sinners, in the closet or hiding behind potted plants. And if you see this CBS documentary in its entirety, you will see men hiding behind potted plants for fear of being seen on national television. From 1985 to 2003, we went from images of suicidal, self-loathing serial killers in TV and film to 1998. Openly gay men starring in an NBC comedy. In 2003, an openly gay woman came into your living room every day, as she has since 2003, never failing to mention her relationship with Portia de Rossi. And then in 2002, the New York Times added gay and lesbian couples to its wedding changes. These are cultural sea changes. And if you want to change hearts and minds, you start here. You see, this journey has and continues to have real impact, because you can no longer be arrested for being gay, thanks to the Supreme Court. LGBT people now have the legal right to marry, thanks to the Supreme Court. This is a story about the power of media to change hearts and minds, what's known as media advocacy. So The Puhl organization does studies on attitudes and opinions quite frequently. And they've done several of them on attitudes and opinions towards LGBT people. And they ask this question: what is the single biggest influence in changing your attitude about LGBT people? It will not surprise you that the number one answer, sort of feels like I'm playing Family Feud all by myself from my home office. Number one answer is knowing someone who is. The technical term for that is contact. You researchers, you come up with the coolest phrases. Now, what do you think the number two, what do you think comes in second place? What is the second most influential way in which people change their hearts and minds about LGBT people? The stories and images in the media. The number two way. This is what we call imagined contact. So think about Ellen in your living room, chatting about her wife. Imagined contact. This equation tells the story for me about what is possible, what is needed, how you can change the narrative and the story about diabetes. Acceptance comes from understanding, and understanding comes from visibility. But fair, accurate, inclusive visibility that tells the whole story. So in 1985, a group of lawyers got fed up with how the media was covering the AIDS epidemic. And they created this organization, GLAAD, the first civil rights organization that focused only on the media, the key to changing hearts and minds. There is not another civil rights movement that has an organization that focuses specifically on the media, news, television, and film. And I believe that this recipe of media advocacy works for any community and any issue. So in the next just few minutes, I'm going to give you a sense of what that recipe looked like for us, what that journey between 1985 and 2003 looked like. The first step in media advocacy is to monitor and to react. So we said to ourselves, well, are LGBT people visible in news and entertainment? Sorta. Were the stories and images fair? No. Were they defamatory and distorted? You bet they were. Did the stories tell the whole story? Did we only see drag queens on roller skates, or did we also see gay alums of Yale? Did these stories reinforce stigma and discrimination? Oh my God, they sure did. And so we started to think about how could we capture the information about the stories that were being told and then mobilize people to raise their voices. And so that's what we did. We started to build an army of people who would monitor the media, something that was harder to do in 1997 than it is to do in 2020, I might add. And I could tell a lot of stories, but I'll tell you two. The 75th anniversary issue of Time magazine hit the newsstands, and I hit the roof. 75th anniversary issue, never mentioned the word gay, never mentioned the word AIDS. We were absent. We mobilized thousands of people to write letters, to call Time magazine, to call them out on this flagrant omission, an omission that told a story all its own. They didn't like that, and not one little bit. They called for a meeting with us, and we told them what the impact of being absent from this issue was like. Here's another case study, the Washington Post. We did this with lots of editorial boards. We monitored the coverage of the Washington Post on LGBT issues. We kept track of the stories that were unfair, defamatory, where they used sources that were not legit. And we asked for a meeting. We sat with them and we said, here's why these are problematic. By and large, people don't want to do the wrong thing. And we educated them. But reacting is not enough. You've also got to get out in front. You don't want to spend your whole time saying, no, that's not the whole story about diabetes. You've got to be proactive and get out in front. And so here are just a couple of stories. So we wagged our fingers at Time magazine, and then came the 20th century issue. Guess who Time magazine called to say, would you meet with us and talk about how we can make that issue inclusive? Well, we had just a few thousand ideas. There was a story about Harvey Milk. We've got Billie Jean King in the sports section of that issue. And that issue was something that Time magazine was so proud about. And in fact, we had awards that we gave to organizations that did a great job in the media. And that year, Time magazine won one of those awards for this issue. And then we met with people and met with people and met with people. And we educated with them and we suggested things to them. So we met with Mark Burnett's people before the premiere of Survivor. And we said, how about a gay castaway? Now, little did we know that the first gay castaway would actually win Survivor, that he was actually a very unpleasant person, and that he ultimately went to jail for tax fraud. Be that as it may, we had a gay character on Survivor. All My Children is an interesting story because it's imagined contact. For millions of Americans, the families in All My Children come into their homes every single day for 30 or 50 minutes. And we were responsible for advocating that they have the first lesbian character on All My Children. I want to go back to the Washington Post because the only thing, we didn't just wag our fingers at the Washington Post. We also gave them suggestions of stories they could tell. And they didn't have to just be stories about gay people. It could be a story about retirement and maybe include a lesbian couple who's also grappling with how to deal with their finances in retirement. And on top of that, we had a training department that trained LGBT people to be great spokespeople in the media. So not only was the content good, but the messenger was strong too. That's the kind of proactive work that makes a difference because you don't want to just wag your finger. You want to help them solve the problem. What were we aiming for? Fair, accurate, and inclusive coverage of the LGBT community in all forms of media. It's important for me to say that the work is not entirely about eliminating stereotypes. Stereotypes are grounded in some reality. It's about advocating for a broad palette of images and stories so that people understand the three-dimensional life you lead. Stereotypes are real, and they're hard to deny. Here are three of them. Many gay men really do love Madonna and will sing show tunes all day and night. A surprising number of lesbians enjoy riding motorcycles. And yes, Virginia, there are drag queens, and many of them march in parades during Pride Month. You can't deny stereotypes. They just need to be part of a palette. I mean, look at me. I'm a walking lesbian stereotype. Here on the left, you'll see me the last time I believe I was photographed in a dress, and as close to a wedding dress as I will ever get. This is my first Holy Communion in 1964. On the right, much more like it. The tomboy at the beach looking cool. I don't think I've ever looked as cool as I look here. This was 1970. So remember, we're not trying to eliminate stereotypes. We're trying to create a three-dimensional picture, in our case, of who the LGBT community was, so that people would understand all that we brought, all of what we were. So the lessons here are: see the media as a point of maximum leverage for fair, accurate, and inclusive story about diabetes. There is money out there. Invest in the work of media advocacy, or create volunteer groups to do this kind of work. My friend Rashad Robinson, who runs Color of Change, which is an online civil rights organization for the African American community, just got boatloads of money from the Ford Foundation to begin to look at how African Americans are seen on television crime shows. Can you imagine how much work he has to do? And third, accept some stereotypes, but educate the media to tell broader stories and be sure to tell them why it matters. Speaking of why it matters, I'd like you to meet my wife. This is Eileen. We've been together since 1983, and she's been a type 2 diabetic since 1994. Here's what she thinks people think of her: that she brought it on herself, that hidden in our freezer are gallons of ice cream that she consumes because she simply can't help herself. Number 3, she's never met a Cinnabon she didn't love. 4, if she could just get out of that Barco lounger, which we do not have, and exercise, things would be different. If only she had some discipline, she wouldn't be a burden on our healthcare system. She thinks people think that she wouldn't know a fresh vegetable if it hit her in the head. Here's what we would like people to know about my wife and living with diabetes. Her blood sugar will spike and then drop like a stone for no reason. And either situation will debilitate her for hours. That the meds she takes actually make it difficult for her to lose weight. That someone will say, you should exercise more, but be careful because exercise can actually make you hypoglycemic and your blood sugar can drop like a stone and you can pass out. My wife wakes up most days with numb toes and she finds it scary. And an overnight hypoglycemic incident caused her to be disoriented. She fell down a flight of stairs in our home. It caused a brain bleed and she had a craniotomy. That's what we would like people to know. That's the lived experience of a diabetic. There are stories out there to tell, and they need to be told. Embrace this power of imagined contact. Think about how you might mobilize and educate journalists, producers, and filmmakers. And like I said, advocate for a palette of images and stories that offer society a three-dimensional picture of diabetes and those that are impacted by it. Because this is the path to changing hearts and minds. You can do this. I'm going to stop sharing and say I'm grateful for the opportunity to share my story. And thank you very much.
Thank you, Joan. I'm going to let us stay there for just a moment. All right, I'm going to let that sink in because I think if you all are like me, this continues a really powerful sort of a chain reaction as we build one conversation onto the next. And I think somebody said there that it was overwhelming, which I think it is, right? Because it is hard for us to combat these stories. And I think to some degree, I think there's some resistance in realizing how much work we have to do, right? And yet I think once we get over that and go, oh, let me ask you out in the chat, who's willing to do some work? You actually go, oh, well, actually I am. Well, I am. Like, there are so many of you. I know your names. I've seen you before. We know each other. We're willing to work. But at first blush, it sounds like, oh my goodness, that's impossible. But guess what? Not impossible. It actually has happened, right? So I find myself a little bit emotionally raw, Joan, after your talk. So I'm still recovering myself, but maybe it isn't right to recover too much, right? Because we actually want to stay in that place, right? We want to stay in this knowledge of what our power really is and what's possible, if we're willing to work for it, if we're willing to change the course of the stories that surround us, to reframe, right? To use research, to speak to those folks who speak in research, right? To recruit our spokespeople, train them, and make a difference. So again, Joan, thank you so much. I think a lot of us are going to be talking for a long time. Our final speaker before we go to Q&A today is Dr. Jim Gavin. Now, I've had both the pleasure and the challenge of introducing Jim before, and I've got to tell you, it ain't easy. There he is. There's Jim. Jim's list of accomplishments is so extensive that it's actually pretty hard to know where to start, right? But I'm going to attempt to simplify this and really cut to the heart of it. Jim is a doctor, yes, and a leader who has made so many people healthier, right? He is the clinical professor of medicine at Emory University School of Medicine and at the Indiana University School of Medicine, because one school is just not enough for him. And he currently serves as Chief Medical Officer of Healing Our Village, right? And he's also the former president of Morehouse School of Medicine in Atlanta and former head of the ADA. And he's the recipient, frankly, of more awards and recognition than I could hope to list. And he makes people's lives better. Right? He is unceasingly giving with his wisdom and his guidance. And in particular, I am awed by his ability to ground this tremendous knowledge and accomplishment and expertise in utter humility and generosity and caring for people. He is our final speaker today, as I said. Please welcome Dr. Jim Gavin.
Thank you so much, David. That was more than kind and gracious as an introduction. And once again, it is my honor to stand before you as part of the diaTribe family, to engage in the demanding process of creative thinking that's designed to develop effective and embraceable strategies for reducing and eliminating barriers to prevention of diabetes and for improving quality of life and outcomes in persons living with diabetes or otherwise affected by it. Now, this is noble and urgent work, and I thank all of you for your passionate engagement. Now, today we address the important matter of diabetes stigma, and you've heard brilliant lectures, and when you're the last speaker in the lineup, there's certainly no further need for me to define it. Here I am, the closing speaker in an absolutely fantastic array of speakers who have really set a high bar. Now, from all that you have heard already, there is clearly great urgency to eliminate stigma in diabetes. It is a suffocating blanket to the groundswell of hope and encouragement that should be the collective experience of persons affected by diabetes, given the rapid advancements in therapeutic interventions and glucose monitoring capability that we have witnessed in this past year alone, notwithstanding the heavy burden of the pandemic. As enigmatic as it may seem, given the circumstances of our general environment, there is much good news in diabetes. Thus, there is heightened urgency to remove all barriers that inhibit and prevent people from seeking necessary care or from fully and openly engaging in the full spectrum of work, educational, and social activities, comfortably assured that they have all of the tools and capabilities for control of their diabetes and the full support of their work, family, and social communities. In short, we need to achieve the curtailment and elimination of stigma in diabetes. Now, I suffer no delusion regarding the magnitude of the challenge, and the other speakers have clearly indicated what a challenge it is we face. I have been asked to provide my perspectives on stigma in diabetes from the vantage point of a physician, which I'm pleased to do. And you'll be happy to know I have no slides. But despite many experiences over the years of seeing the exercise of stigma and its myriad deleterious effects in diabetes, that is not where or how my experience with stigma began. Many of you know that I was inspired to change my career direction from that of a PhD bench scientist to a physician scientist when I discovered that it was diabetes that was responsible for the deterioration and ultimately the death of my great-grandmother, who was a beloved and revered person in my life and in the life of my family. She was so full of kindness and generosity and wisdom, and was a fierce protector from the wrath of parents and grandparents alike. She was always our place of encouragement and comfort and tea cakes. And we eagerly anticipated our summer journeys from Mobile to Selma, Alabama, to visit her. I vividly recall that summer when we arrived in Selma, and it was not Mama Rennie bursting through the door as the first person to greet us, because she was bedridden. She looked nothing like she had looked the previous summer, and shockingly, one of her legs was missing. As kids, we didn't quite know what to say or do, so we mimicked the withdrawn behavior and hushed tones of the adults, all the time wondering, but too reticent to ask our clearly distraught parents, what's wrong with Mama Rennie? They volunteered nothing, and we were left to piece things together as best we could. Every once in a while, we would overhear a reference to her sugar or that sugar, or some reference to what the sugar was doing to Mama Rennie, and it made no sense. We surmised as kids that whatever calamity had stolen Mama Rennie's vibrancy involved terrible actions of sugar. Clearly, they were leaving something unsaid, because sugar was sweet and pleasant and would never do that to a wonderful person like her. It was many years later that I realized that it was diabetes. And the grown-ups did not want to discuss it out loud around us as kids. It was my first encounter with stigma. It's not likely to have been simple denial, because the issue was so glaringly obvious. It was stigma. It was not a proper thing to talk about or to acknowledge. I had to learn that my great uncles, one of my sisters, and other family members also had sugar, but it was never acknowledged at family gatherings or in discussions. These were early, missed opportunities to learn the most rudimentary things about the disease. For in those days, it is fair to say that we didn't know much, and we certainly had insufficient tools with which to address the condition. It was stigma driven heavily by fear and ignorance. But that was my first encounter with this entity, which is the target of our efforts to change the narrative and displace the practice. Let's fast forward nearly 65 years. I was taking care of some banking business at my local community bank, talking with one of the veteran executives here in small town of Oviedo. I'll call her Lisa, whom I'd gotten to know since moving here to Florida. She wanted the bank president to weigh in on our discussion, so she brought him in. Now, we had met before, so we made small talk and then proceeded to address the business matters. He left, but then he returned shortly to ask me to remind him once again what it is that I did. I mumbled a few things about my career activities, but I finished by saying, I am above all else a diabetes doctor. Lisa said, diabetes? Well, Bill and I both need to, oh dear. I need to shut up, she said. I talk too much. She was clearly ready to change directions and talk about something else. He said nothing more, but simply said that he looked forward to talking with me further about the business matter that we had discussed. Lisa and I completed our business, with her seeming more ill at ease than I had ever known her to be. And I confess that because I had a Zoom call in 20 minutes, I missed a valuable opportunity to address this professional, efficient, and very nice woman at an important point of need. Clearly, she felt she had let the cat out of the bag, had revealed some secret information about her and her boss that never should have been uttered aloud. Did she fear judgment from me? Even after I admitted I was a diabetes doctor, that was not enough to assure the comfort of a certain comradeship? Now, the more cynical might think, well, it's really very personal information. Or it might diminish their professional hauteur to be seen as having a disease of negligence, or to be seen as having insufficient discipline to avoid such a disease. Now, there are even those who would surmise that because they were white and I'm black, such an admission would imply a kind of weakness that is historically to be avoided. The scourge of stigma conveys an undeserved taint to even the most basic elements of human discourse. What became clear to me in that moment was that she was suffering from the captive effects of stigma, and I had the opportunity and even the duty of providing a certain liberation. And I blew it. I wondered how many other times I had failed to address a patient's needs when they uttered things like, Doc, I know I need to do better, but sometimes it seems my best is just not good enough. So many times I have heard the resounding cries of, it's my fault, I just don't have the willpower. Or worst of all, I guess we all got to die of something. Far too many times have I witnessed the ability of stigma to drain energy, exterminate hope, and impose silence and reticence where there should be comfort and benefit of open exchange, especially since there is now so much good news to share. I have the opportunity to share the power of change and the hope that is now an incontestable reality for persons living with diabetes or affected by it. It is no longer my great-grandmother's disease. I should have shared that hope with Lisa. I am pleased that I do so more often than I do not. So my behavior with Lisa and Bill was not typical. Okay, I sort of blame it on Zoom. But now I advance a different narrative about diabetes. I guess I have already started the reframing process that is so essential. And I challenge other healthcare providers to consider doing so, as you have been challenged already. Diabetes is a common. Patients need to know that they are far from alone, preventable, and completely controllable chronic disease. My good friend, Dr. Bill Polanski from San Diego, echoes and shares my strong view that well-controlled diabetes is the leading cause of nothing. I assert that these outcomes are possible because each person has the responsibility of becoming an expert in only one case of diabetes, their own. My job and your job is to help them comfortably achieve such insights and expertise, and to embrace the transparency that comes from stripping a condition of its mystery and hopelessness. Certainly, it begs the question about how we should prioritize our efforts to reduce the impact of and eliminate the exercise of stigma. Should we be working harder and more smartly at reshaping the narrative, reframing, as it were, and improving the awareness so that this complex yet common disease is not perceived any longer as the fault of an undisciplined lifestyle? Even though structured changes in lifestyle can be effective measures to prevent and treat it. Can this disease gain more parity with breast cancer, which is never considered the affected woman's fault, although we depend on her vigilance and awareness to assure early detection and to promote the best possible outcomes? If we can successfully recast the very perception of diabetes, and we won't delve into the nuances of its complexity for the moment, might we prioritize the societal inclination towards engagement of diabetes stigma as the principal target for change? Or should we instead spend more energy on strengthening self-awareness of the individuals who are the recipients of stigma and help them become more resilient, to become masters of deflective behavior so their hope and confidence are not damaged in their journey to the newer and better outcomes that are now possible? Perhaps there's no choice except to do both. We must confront the what by acknowledging, as you've heard, brilliantly portrayed, that stigma is real. It is damaging, and it is a barrier that diminishes the ability for the kind of progress that is now possible using the newer treatment tools and interventions. Now, it's certainly not the only barrier, but it is exceedingly common, almost cultural in its penetration and impact, and it is persistent. It has far-reaching and often lasting deleterious impact. We must confront the how by engaging in activities like these, where we seek to define strategies to better understand the dynamics of and the motivation for stigma, to inform approaches to reduce and eliminate it, while at the same time helping patients to avoid being suffocated and rendered hopeless by it. This is the part that challenges us to communicate better what diabetes is and what diabetes is not. Most importantly, this is the part that challenges us to convey the good news that derives from new insights, new discoveries, new technologies, new treatments, and extensive new data regarding better outcomes at every level of diabetes, across ages, genders, ethnicities, and durations of disease. New data and new tools allow us the opportunity to shape and promote a new narrative about diabetes, one that disempowers stigma. My view is that this is where we might want to spend the bulk of our time and energy. While I would never want to minimize the problem, I don't need to celebrate it or dissect it further when there are very smart and eloquent people who have done a fabulous job of giving clarity to the nature, extent, and impact of this problem. What is more, We can share with our patients the fact that there are many fine examples of people who have dealt with stigma and have realized the advantages of a full life with diabetes in which there is no fear of transparency, for they have achieved comfort with knowing that they are not diminished by their condition. They have affirmed that this is a controllable disease, and well-controlled diabetes is the leading cause of nothing. We now have the collective testimony of Anthony Anderson, Tom Hanks, Nick Jonas, Drew Carey, Randy Johnson, Billie Jean King, Jay Cutler, Patti LaBelle, just to name a few. The why is perhaps the most straightforward of all our discussion. And here my work as a person providing the physician perspective on stigma has been made really easy. Let me quote something that you should probably find very familiar. Stigma is problematic and creates barriers at nearly every step of the diabetes pathway. The possibility of stigmatization and judgment discourages individuals to undergo screening and diagnosis for fear of being labeled diabetic. Once diagnosed, people with diabetes may not adhere to their medication regimen or properly monitor their blood glucose in order to avoid judgment from others. After years of living with diabetes, people with diabetes may also accumulate increasing mental and emotional stress due to the associated stigma, in turn leading to increased risk of complications and worse health outcomes. Finally, as we have learned from other social movements, and you heard this brilliantly from Joan, such as the LGBTQ rights movement, stigma, discrimination, and concealment hamper our ability to enact effective collective action to bend the curve on the diabetes epidemic. Thus, it is impossible to make significant progress in diabetes without first eliminating stigma among people with and without diabetes. This should sound familiar because this is an eloquent statement of why we are addressing this issue, and it is the closing statement in our briefing document for this meeting. Maybe, just maybe, I shall go back to Lisa and Bill and suggest that it would be nice if we had a talk. Thank you very much for your attention.
Thank you, Jim. Once again, Jim continues to lead the way, this time not with a strategic arc, but with an honest view of his own behavior, right? And I think, you know, I am moved again and thinking a little bit about Ibram X. Kendi's book, How to Be an Anti-Racist, and thinking about the evaluation. He says we must combat racism in all places, including perhaps most importantly in ourselves, right? And to think about this notion that all of us, even though we may be advocates, we might care deeply and not wish any harm. We're wishing to support and do well by each other. And yet we are part of the story and part of the stigma. And there may be ways that we can all improve. I'm going to ask all the speakers to come back to the stage, as we have time for a couple of questions. I know some of our speakers have to leave before some others, as we're a little bit over our time. But thank you all. Listen, first of all, can we just offer them all in chat a huge thank you for their expertise, wisdom, brilliance, courage in sharing with us today. It's really been a powerful evening for all of us. You know, I'm thinking also about even something that I have said, I have repeated, and you know, Jim Gavin was talking about how diabetes is the leading cause, well-controlled diabetes is the leading cause of nothing. And I'm wondering even about that, the statement, which I've repeated many times. And we're talking about that as a sign of hope, right? We intend it as a sign of encouragement. And yet I know people who have worked really, really hard 12, 13, 14 years old who have complications. And what does that mean for that person, right? So even inadvertently, we might cause harm, right? So I think this is a conversation that begs more consideration, right, for all of us. I'm going to start our first formal question to Nat. Nat, this question came from George, I believe. Said, Joan told us a bit about the success and continued struggle of the LGBTQ movement with reframing and creating a new narrative. Are there other examples you know of where this method has worked or shown big successes? What have they had in common?
Yeah, so I'll try to answer this. I definitely am a person who studies social movements and the kind of media campaigns that Joan talked about, but Joan could also answer this, I imagine, from a different perspective and has a list of her own. But there's some canonical or kind of seminal examples of this. The example that Joan gave is I think one of those and is the most kind of inspiring and I would say kind of instructive and hopeful. But tobacco is another one. Tobacco went from being framed by members of the field as kind of an individual vice. And if something is an individual vice, then the solutions that people support correspond with that kind of idea of causation. And the key shift that advocates made was from tobacco as individual vice to tobacco as defective product. And as that shift was made, and it wasn't just one time by one organization, public thinking and attitudes around solutions started to shift. And there's another ones. There's been mental health campaigns, which I think have some similar issues to diabetes in other countries. There's a well-known one in the UK called Time to Change. There's also some fantastic death penalty abolition work that's been done in this country that has really changed public thinking and policy in remarkable ways. But just to kind of call out some of the things that are kind of threaded through Joan's story is the fact that the issue has to be moved from kind of out of the public view to into the public view, right? It has to become salient and something that is top of mind and discussed. There has to be a common frame, and there has to be discipline across organizations and over time in advancing that common frame. I mean, the framing that Joan talked about did not happen, although many people think it did overnight in a legislative cycle. It was years, it was decades of committed work, of careful research, of discipline. I think there need to be multiple channels used, right? So it's not enough just to go through social media or entertainment media or certainly news media or certainly advocacy, but these efforts require kind of all of those modes of influencing hearts and minds, of influencing thinking. And then I think a really important piece of all of these examples is that there has to be a solution. It has to matter to people, and it has to be something that people think is feasible and around which there can be built some efficacy.
Thank you. Yeah. You know, I'm thinking these days, both in terms of challenge and opportunity, the fragmentation of media. And I mean that obviously we have these huge media conglomerates, but people get their information from so many places, including from like their third cousin on Facebook, right? Who's just posting something up there. That there's both an opportunity there for many people to be advocates and a challenge because there are so many ways to deliver story and news, right? Joan, why don't you jump in? You look like you're raring to go.
And I'm semi-raring.
Go ahead.
I teach a class at the University of Pennsylvania at Annenberg on media advocacy. And I was actually going to answer the question differently and say that one of the places where I think we actually don't do a very good job is how the media portray women. And one of the exercises that I do with my students is I have them read, they have to get a hard copy of the New York Times, which is a challenge in and of itself.
Yeah.
And their assignment is simply this: you have just landed from another planet. You know nothing about this place called Earth. And all you know is what you see in this issue of the New York Times. Tell me what you've learned about women. And it is one of the most powerful exercises. Who writes the stories? Who are the sources? And so, I do feel pretty strongly that you're right. It's quite fragmented, David, but I also think it is a strategy that that does actually. I firmly believe that it does move the needle. I see, David. Can I just grab Karen Yan's question? Question.
Karina posted that to you. The question came from a participant. Yeah.
Oh, so it came from Lisa.
Yeah.
And actually, it's a great question. Is how do you approach people who are resistant? I'd love Nat to jump in on this too, because so one of the ways that we framed marriage equality, we started out wrong and then got it right. We started it out by claiming that it was a right that we deserved. And the truth of the matter is that people who get married don't think of it as a right. There happen to be 1,365 rights that come with a marriage license, but it's not the framing that resonates for people. What resonates are values. What resonates are love, commitment, family. And so I have found that with people who are resistant, the more able you are to be able to identify those common values, that's just the ties that bind, right? Is that we would fight with, argue on national television. No, it's not a right you deserve. And it was a losing proposition for us because it just wasn't framed properly. Because it wasn't seen as a right, and it wasn't seen as something we deserved. But if you said, do you believe that people should live happily ever after? You can almost always get people to say, yes, they should.
Yeah. Yeah. That's beautiful. That's beautiful. Thank you. And actually I'm thinking as you answer that, I'm thinking about Sonia Renee Taylor. Those of you who are familiar, she has a book called The Body Is Not an Apology. She actually says acceptance is not enough, right? It is too passive. I accept that, right? It's too passive, that it actually takes love, right? Affirmative.
When I was at GLAAD, I was told by many that I needed to argue for tolerance. And my wife said, wise person that she is, she said, I hate that word. She said, I tolerate lima beans.
Yeah. So I'm wondering how we can, both with considering framing and the power of this communication, how we can set the bar higher, right, than tolerance, if you will, acceptance. Acceptance is only a stepping stone on the way to something greater, I think. Nat, I know you may have to leave as well, so if you do, thank you for the time. If you can stay longer, great. But if not, if you have to drop off, we totally understand and we appreciate all that you've contributed. Rebecca, a question for you. This question comes from Aaron. Internalized stigma is especially challenging. What are some tools or techniques that a person with diabetes can use to be able to help ourselves with internalized stigma and are challenged with managing it to allow us to effectively manage our condition?
That's a great question. And, sometimes the most negative messages we hear are our own messages. And these are ones that have been internalized by broader societal messages that just aren't getting challenged in the way they need to. And, trying to address that internalization in yourself can be really challenging. And it's a matter of self-compassion and self-kindness and positive self-talk and really practicing those strategies, which is not always easy when the voices you hear around you are making you feel shamed or stigmatized. Seeking social support is an absolutely fundamental strategy if you are internalizing stigma, whether it's a family member, a close friend, someone at work. And I think as part of that too, as speaking as a psychologist, that it's very important that healthcare professionals understand the damage of internalization and be aware that the internalization of stigma really does impact emotional well-being and physical health. And in some ways, it's up to healthcare professionals to really ask our clients and patients about the experiences that they may be having because of stigma and whether they're turning those experiences inwards.
Yeah, thank you. And I think, Jim brought that to our attention also quite clearly, right? As clinicians are also people, right? We have to, who have to handle their own belief system and frankly, what kind of day you're having. Like you're just going about your business doing something and yet some sort of outsized responsibility. And honestly, I think too much responsibility is placed on the clinician, right? To be the arbiter of all truth, all advocacy, all remedy, all intervention, right? That I think we need to share that burden a bit. So I also know Joan had to leave. So if we can say goodbye to her, she had to go as well. I know we all thank her for the inspiration she provided and wisdom. So thank you, Joan, if you're still with us there. I'm curious if you guys will bring some more questions in. Actually, here's the first one. So I'll put my questions on hold. This is a question for Jim from Amy. How do you wish people communicated diabetes to you as a child when you were observing your grandmother's experience and her diabetes-related hardships?
Yeah, I think, of course, I can't possibly know what my level of readiness would have been for anything that they would have said, but I think it would have been helpful to call it by name and to simply assure me as a child that this is something that is happening to Mama Rennie, but it happens to other people, and you supplement that with whatever knowledge you have about the why. Okay, but I think to be forthright in terms of its presentation, and then to say what you know to the child, in that case to me, about what it means that we should be helping Mama Rennie to try to achieve, and what our role now has to be in supporting her. I think this would have been an important frame setting in my mind, as opposed to shrouding this whole thing with mystery and quite frankly, fear. I mean, it scared the bejeebers out of me. I mean, hell, her leg was gone. And I didn't tell the whole story, but the following summer, we came back, it was worse. Her other leg was gone. And that was the last time I saw her alive. So there was a lot that could have been done in terms of the narrative to help avoid the mindset of that mystery and fear that was left.
I really do believe that most of the times we're silent, it's out of some level of fear, right? Like when we don't talk to our kids, for example, or our patients or our doctors. I mean, I know I've had a lot of doctor friends who've told me about the what do they call it? The doorknob question. They say, you have your time, you ask all these questions, you have this whole conversation. And then literally as you say, great, well then you spent all your time and you're on your way out the door. You have your hand on the doorknob. And then someone says, oh, by the way, doc, I have shooting pain down the left side of my arm from my back. And you're like,
that happens more often than I want to admit.
Right.
But the
fear that keeps us silent in those moments because we're like uncomfortable and we don't want to bring it up.
And I think now, David, the opportunity that we have, and I say the obligation that we have as providers especially, is to communicate the truth about diabetes as a very different disease. This is not Mama Rennie's disease anymore. Yeah. We really need to actually make sure that people understand that and know what those new possibilities are and what it means for them. And not only that, but what they can achieve. That's our job as managers, as coaches, as technical assistants in the healthcare provider arena. And it's what we're doing here as part of an exercise like this.
Like, I guess there was a time when you didn't talk about it because you couldn't do anything about it.
Absolutely. It was probably the most common reason for not talking about it.
As that fact has changed, our response needs to change also. Our behavior needs to change around it. We are way over. We've imposed on your time so much. it has been a pleasure getting to know all of you, all of our speakers. Thank you from the bottom of all of our hearts. I really do feel like today is the start of something. I feel like there has been a conversation that has been growing, and I think this is sort of another log on the fire for this. And hopefully this is a point from which we cannot return. So thank you all for speaking with us and sharing your time. Jim, Rebecca, have an amazing week. To all of our audience, thank you for all the questions, all the engagement in chat, all the stories. We are listening. We have lots of folks in chat who have been listening to you guys and trying to track stories and comments. So we will we'll be following up as best we can. Also, go visit diatribe.org. Right, both at this talk will be maintained. Will be preserved so you can share it and keep these conversations moving. From here we grow and we grow up. Up is good in this case, right? Up is good. Thank you so much, everyone, and stay safe.
Thank you.